although it is not very common as compared to the cirrhotic portal hypertension, but it is an entity that is non-cirrhotic portal hypertension. So let us listen the scholarly thoughts from Professor Ghias Tayyab on the management of non-cirrhotic portal hypertension. Professor Ghias Tayyab is a well-known professor of medicine and gastroenterology at the Postgraduate Medical Institute, Lahore. He is also the project director of Punjab Hepatitis Control Program, and he has the large number of the research papers in his credit in the national and international peer-reviewed journals. Professor Ghiasun Nabi Tayyab is teacher of the teachers. He is eminent scholar and an interventional endoscopist. He has been one of the pioneer in endoscopic ultrasound and endoscopic management of the biliary and pancreatic diseases. So today he will talk on the management of non-cirrhotic portal hypertension. Please, sir.
Yes, Manavan. Thank you very much for the kind introduction. And I'm thankful to the organizer of Pakistan Society of Hepatology for inviting me here. And after hearing an elegant talk by Professor Javed Farooqi on the cirrhosis side, my job is to talk about non-cirrhotic portal hypertension, which is a wide array of the topics, and I'm just going to touch the basics of this vast subject. I'm not going to delve into the details. I don't have any financial disclosures relevant to this presentation, and my boss had given me the warning that I have to present this slide at every cost so that everybody may know that next year from 22nd to 26th of February, we have the 39th annual conference of Pakistan Society of Gastroenterology. So vascular diseases of the liver, it's a large collection of the diseases, not a single entity, starting from hepatic veins on the other side to the portal vein, and in between you have the liver, and you have listened to the liver side from Professor Javed Farooqi. So if there's a problem in the hepatic vein side, or if there's a problem in the portal vein side, we know that if there's a problem in one of these vessels, there's going to be non-cirrhotic portal hypertension. Liver is going to be fine, but portal hypertension is going to be there. And rough incidence is about 5 per 10,000 patients, and it is a very, very important disease. And let me tell you that in the past couple of years, ever since the COVID has come, we have seen more number of cases suffering from acute portal vein thrombosis and resultant complication as compared to the previous years. Whenever there's acute portal vein thrombosis, acute hepatic vein thrombosis, we know that it's associated with significant morbidity, it's associated with significant mortality, and the life expectancy gets compromised. Generally, these patients are young, and most of the time in our part of the world, the patients are very, very young. So it's important that we need to look at these patients carefully. A couple of studies which have been worked on in Pakistan, it's very important that the commonest cause of non-cirrhotic portal hypertension, especially if we look towards the portal vein, that's childhood or neonatal sepsis, leading to infection of the umbilical vein and portal vein thrombosis. And generally the patients present in the early teens or late teens, and they are in miserable condition. They are cachectic, they have got huge spleen, at times they have got ascites as well, but most of the time these patients present with bleeding varices. And in a study conducted in Islamabad by Dr. Javed Bhatt and his team, 90% had ischemic varices, 25% had rectal varices, and 80% had liver histology, only 20% had ascites as well, and mostly they presented in the age group 15 to 35. This is the main manifestation of the people who are suffering from non-cirrhotic portal hypertension, and this is another manifestation: bleeding, gastric varices or gastric varices on the endoscopy. Why do they explode? Dr. Javed Farooqi has given us a very clear landmark that if the HPPG goes beyond 10 millimeters of mercury, that's the time that these vessels tend to get burst. And the more the flow and more the size of the varix, greater are the chances that these patients are going to burst. And this cartoon shows the various causes, starting from the hepatic vein side, that we may have Budd-Chiari syndrome, inferior vena cava obstruction for any reason, pericarditis, especially in our part of the world, consecutive pericarditis is quite common, right heart failure for any reason, and tricuspid regurgitation can lead to development of non-cirrhotic portal hypertension in these patients. On the hepatic side, arsenic poisoning is something, schistosomiasis in Middle East, but for us It is arsenic poisoning which leads to idiopathic portal vein fibrosis and congenital hepatic fibrosis, nodular regenerative hyperplasia, and other veno-occlusive diseases because of the exotic drugs which the people love to take from hakims and non-traditional doctors. And on the pre-hepatic side, the portal vein thrombosis, it may be acute, it may be subacute, it may be chronic, and then it may be arising in the form of one segment of the portal venous system leading to portal hypertension in one segment. And this cartoon depicts the problem in various parts. If we look at the top, we have the hepatic vein obstruction. On this side, we have the iatrogenic or nasal vascular shunts, sinusoidal problems, and then we have the portal vein thrombosis. And if there's a splenic vein thrombosis, then a person can have a left sectoral portal hypertension, again a very, very important cause, and endoscopically a very challenging cause to manage, and at times we have to look beyond our own domain to look for the treatment. What is the unifying hypothesis? Either there's a prothrombotic state, or there's inflammation, or there's a structural abnormality, and finally some iatrogenic event that the people develop the thrombosis at various levels. It can be of multiple varieties, and that's the reason that I said that I'm going to touch just the basics of the topic. It's not a straightforward topic. When we have the splanchnic vein thrombosis in patients with underlying liver disease, we have Budd-Chiari syndrome, acute portal vein thrombosis, extrahepatic portal vein obstruction, idiopathic non-cirrhotic portal hypertension, hepatic vascular malformations, in hereditary hemorrhagic telangiectasia, and sinusoidal obstruction syndrome. This is the sum up of the common causes that we come across in these patients. And Budd-Chiari syndrome or hepatic vein thrombosis is something that we see quite commonly. Maybe in the while sitting in the referral centers, sitting in the teaching centers, we get to see more number of cases. In the community, they are not all that many, but definitely something that we get to see roughly 1 to 2 cases per week. And the causes are manifold. The commonest cause, either it's related to malignancy or to a drug. And if a patient presents in a younger age, mostly this because of vascular malformation, either in the form of web in the vein, or some childhood hereditary thrombotic disorder in these patients. At times, people with hepatocellular carcinoma, we all understand that we are passing through a phase where we have started to see more and more number of cases of hepatocellular carcinoma, and we have seen quite a good number of cases of these hepatocellular carcinoma patients invading into the hepatic vein. So again, a cause which is coming up quite commonly. What do we see in ultrasound? Pruning of the blood vessels, pruning of the hepatic veins along the sphere spectra of the liver. And this CT scan, once you've seen this, a bulky liver which is devoid of blood vessels, or in other terms, although not the classical picture of the nutmeg, if the things proceed beyond that, a classical nutmeg appearance of the liver. These are two classical pictures. Once a person has seen, once a student has seen these two pictures, they can never miss the diagnosis of Budd-Chiari syndrome. So when we say splanchnic vein thrombosis, we are basically including two things. One is portal vein thrombosis, hepatic vein thrombosis. Both conditions are caused by an uncommon prothrombotic disorders, but then congenital webs and these things also exist. Etiology, but for there are more than 2 factors in more than 46% of patients and 10% of patients respectively. In more than 60% of patients with splanchnic vein thrombosis, inherited thrombophilia can also be considered as risk factor. But I think these statistics pertain more to the West. On our side of the world, it is the dynamics are different, and the causes are more towards the infection, inflammation, and structural disorders, because the patients tend to present at a much younger age group. Looking towards the West again, the statistics that we have, thrombophilia, myeloproliferative disorders, hormonal factors, they are common, no doubt, over there, and they are present in our society as well. These factors can exist here, there too, but definitely, what are the exact statistics, we don't really know. But for the knowledge of the audience, yes, these are the things that we need to consider. Once the patient presents, what do we need to do? we have three sets of things. One is medical treatment. The other one is with the help of interventional radiologists. I can see Dr. Najam sitting in the audience. He's one of the pioneers in these procedures. And then TIPS, again, a procedure which was started by Dr. Najam in a country. So these are three mainstays of the treatment. And if nothing works, uh, finally the rescue therapy, that is liver transplantation. That's what we need to do. What is the medical treatment that we need to consider? Anticoagulant, anticoagulant, and anticoagulant. That is something. Earlier we start, better it is. The longer we give, the better it is. What is the stopping rule? Nobody really knows. But at least once we are sure that we are not dealing with a prothrombotic state, and once we are sure that the veins have been recanalized completely, only then one can stop. But in how many cases are we really able to stop anticoagulants? Answer is not in many cases. Uh, there's always a possibility of bleeding potential, because if a patient presents late, these patients do have varices as well. These patients have got portal gastropathy as well. They tend to bleed from those sides as well. So one has to make a balance between the two, bleeding tendency versus prevention of extension of the coagulum and recanalization of the blood vessel. At times, intravenous, if the patient presents early, intravenous injection of the fibrinogen lytic agent, that can also be considered. Angioplasty, stenting, something which is very exciting. Um, there used to be lots of enthusiasm about it, but then it is associated with a caveat that people tend to have rethrombosis of the blood vessel, and stenting alone of just a short segment may not be a good idea. But definitely TIPS is much better, where we take the stent all the way from one end of the hepatic vein to the portal vein, and the chances of occlusion are much less as compared to just the stenting of the hepatic vein, one hepatic vein or the small hepatic vein. And finally, liver transplantation, when we when the patient is presented late, when the patient is not getting rescued with the other therapies, yes, at that time liver transplantation is the choice of the treatment. Extrahepatic portal vein thrombosis, people can present in an acute fashion. People can come with tumor related. Again, liver cancer patients are presenting more and more in the number. And every time a patient presents, the first thing that we look at the CT, and first time we look at the report is portal vein thrombosis there, or is portal vein thrombosis not there? So important differentiation in terms of management decision. And tumor related portal vein invasion, or tumor thrombus in the portal vein, is something which we are coming across more and more commonly. And chronic hepatic vein thrombosis, obviously starting with the childhood, and so many other factors that we know. How to go about in a patient who is presented with acute portal vein thrombosis? Again, one has to make a balance between anticoagulants versus chances of bleeding. And let me tell you, again, in this patient, just like hepatic vein obstruction, anticoagulant, anticoagulant, and anticoagulant. What are these stoppage rules? Nobody really knows, but definitely once the vein has been completely recanalized, once the blood flow is adequate, then one should take the chance of stopping the anticoagulant. And which anticoagulant? Low molecular weight heparins. I've been part of rivaroxaban trial, and similarly a couple of other trials as well. The low molecular weight heparin and coumarins, they work equally well, but in the initial while, maybe heparin infusion works better in these patients as compared to low molecular weight heparinoids. When there's significant congestion of the interstitial mucosa, at times people tend to go into severe venous congestion and venous gangrene. Should we go for laparotomy? Should we go for resection? At times we do have to, but one should make every attempt to avoid going for intestinal resection, and the avoidance should be as much as possible. Close monitoring has to be done, and at least 6 months anticoagulant needs to be given. And mind you, in the past 2 years, what we have seen, that we start to see more and more number of cases presenting with acute portal vein thrombosis, presenting because of the COVID-19 infection. And the same phenomena has been seen by people in the rest of the world, and the reports have been published here in Pakistan as well as outside Pakistan. Um, is there any role for permanent anticoagulation, long-term anticoagulation in chronic extrahepatic portal vein thrombosis? And should we go for stenting of extrahepatic portal vein thrombosis? I'm lucky to work with one of a very aggressive interventional radiologist who happens to stent in the extrahepatic portal veins. We have seen the mixed results. I'm not going to dwell on the results yet because these in the process of publication will not be fair for me to discuss those results here. But definitely long-term anticoagulant in these patients, they work very well, especially it prevents the extension of the thrombus and improves the quality of life of these patients. In the last few minutes, I shall like to concentrate on the left sectoral hypertension, which I've seen the most challenging one. And if you look at this cartoon, just below the liver, just under the gastric bed, at beyond the neck of the pancreas, we have the thrombosis of the splenic vein. And when this thrombosis of the splenic vein, all the blood which is going towards the spleen, that has to come back towards the portal system through the splenic vein. There's going to be a massive enlargement of the spleen. There's going to be massive buildup of the pressure in these patients. And when these patients bleed, they bleed heavily. Cause can be post-pancreatitis, can be post-traumatic, post-iatrogenic injury, or it can be idiopathic as well. And when they present in the acute phase, they present with severe abdominal pain along with fever and vomiting. But in the chronic phase, it's all about these varices, and when these varices bleed, they bleed so heavily that they become difficult to manage. And for all the young audience which is sitting, once you have seen that there's a splenic vein thrombosis and this left sectoral hypertension, they're a different ball game altogether. Involve the interventional radiologist, involve the surgeon right away in the management, and keep the person in the ICU, because these patients can bleed, and they can bleed heavily, and they can come to you at any time. Tissue glue, do they work? It's always a very tricky situation because there are lots of bypass channels already made. Injecting the tissue glue at the right speed, injecting the right kind of tissue glue, that remains a challenge. The moment you inject more aggressively, the tissue glue is going to go into the pulmonary vasculature, leading to pulmonary embolization. If you inject relatively slow, the needle is going to get coagulated. So there's going to be an issue in the injection of the tissue glue. Next is US guided tissue glue and coil embolization. A good technique. Personally, I've not practiced, but I always fancy that this is the technique to deal with these patients. IO-guided recanalization with the help of balloon retrograde, balloon-occluded retrograde transvenous obliteration or recanalization, or transplant recanalization, again something which can be done. And in the acute emergency situations, let me tell you, uh, even in the inexperienced hands, splenic artery embolization is the best way to go, because it reduces the blood flow going towards the spleen, and that's the blood flow which is going to dictate the ultimate pressure which is going to come back towards the obliterated splenic vein, and dictate the outcome of the bleed coming from the gastric vessel, esophagogastric vessels. Once again, a reminder for the conference coming next year, and I thank you for your patient listening.
Thank you, Professor Ghias and Nabi Saab, for the wonderful presentation on the complex topic.